And happy Friday to everyone. Why is it a happy Friday, you ask? Well, because today is our return of Grand Rounds. It's the first one of the 2025-2026 academic year. So thank you all for being here. This is Grand Rounds, presented by the Department of Psychiatry and Behavioral Sciences. And my name is Jed Thompson. I'm the Associate Director of Communications for the department, and I'll be your host for Grand Rounds. You can maybe see we've got a lot of people online here today. We've got a great presentation. We've got 4 speakers lined up, so it's kind of a party here on the webinar at the moment. A lot of people to introduce, but before we do that, while we're waiting for people to get logged on, get settled in, I will go through some of the logistics for our Grand Rounds presentations, especially for those of you who are out there joining us for the first time. So first things first, you may have heard when you logged on that this presentation is being recorded. So we'll record all of our Grand Rounds, and they will then be posted on our YouTube channel within a day or two. You can go back to the archive, you can watch today's presentation again, or actually you can watch any presentation going all the way back to 2010, I believe. We've got a huge archive out there, so take a look at those. We may or may not have a little bit of time for questions at the end of the presentation today. We'll see how much time allows, but if you have any questions, we have the comments feature open and we have the Q&A feature open as well. So go ahead, anytime you have a question, go ahead, plug it into that Q&A section. We'll answer some of those live during the presentation through text answers, and any we don't get to through text answers, we'll do a live Q&A answer session at the end. Okay, if you enjoy what you see today, if you want to give us some feedback, we have an evaluation form that's going to show up after the webinar closes. We'll all disappear, and a link for that survey will show up on your screen. So go ahead. We'd love to hear your feedback. And if you like what you see today, hopefully you'll join us again next week. We'll have another presentation next Friday, September 19th. Dr. Michael Compton will be joining us from Columbia University. So with that, why don't we go on to the next slide? And I am going to now hand it over to the chair of our department, Dr. Jürgen Unitzer, who is going to introduce today's speakers. So I'll disappear here now. I'll return at the end. But for now, I'm just going to toss it over to you, Jürgen.
Okay. Well, good afternoon. Welcome, everybody. Welcome to our first Grand Round presentation of this academic year. And as Jed said, today we have, to start you all off, we have not 1, but 4 presenters. We're going to hear from several of our colleagues here at UW about a new center here at UW, the UW-WHO Collaborating Center in Mental Health. I'm going to tell you a little bit about our speakers, but then I'll try to get out of the way because you really want to hear from them. Leah Nguyen, Lydia Swastiak, Ian Bennett, and Larry Wissau are going to tell us about the UW Consortium for Global Mental Health. That's a partnership between our department, psychiatry, and the Department of Global Health. And it's a partnership that was recently designated a new World Health Organization Collaborating Center in Mental Health. Lydia is an internist and a psychiatrist. Her interests have really focused on the intersection of chronic medical illness and serious mental illness. She works clinically at Harborview, and her research has looked at how cardiovascular risk factors affect the lives of people with serious mental illness. She has done some really great work on collaborative care for depression and diabetes in places as far away as India, and work on an innovative community mental health center-based team approach to treating poorly controlled diabetes in outpatients with schizophrenia. Ian Bennett is a family physician. Ian has a joint appointment in our department, and he focuses his work on delivering primary care services to vulnerable populations in the US and also in developing countries. He's an expert in implementation science. He is studies the implementation of collaborative care for perinatal depression in community health centers here in the US, but also in places as far away as Peru and Nigeria. Larry Wissow is trained in pediatrics and child psychiatry. Larry's work has focused on addressing psychosocial problems in children and families with a particular interest in what happens and how that happens at the interface between primary care and mental health care. He's worked in this area in urban and rural environments here in the US, in different cultures, and in different countries, places as far away as Brazil and Ethiopia and Iran and Pakistan. And then leading off the presentation today is Leah Nguyen. Leah joined the UW Consortium for Global Mental Health as a program manager in 2023. Leah is trained as an artist and a social worker. She's done some great public health policy research at a prevention research center. She's worked on creating a holistic university wellness program, and she's done a lot of work in youth development programming, advocating for state policy changes in foster care and homeless youth. So a great set of speakers, a great topic. And so today we're going to hear from this great team of colleagues about their experience with setting up and getting off the ground this new WHO Collaborating Center. So with that, welcome to all of you. I think, Leah, you're leading off. Is that right?
That's right.
Very good.
So hi, everyone, and thanks for being here. I want to first introduce you to the structure of the WHO Collaborating Centers in general. And just before I even do that, I want to just say that the WHO is an authority that's responsible for directing and coordinating the United Nations efforts on international health. The first collaborating center was actually established in the same year as the World Health Organization in 1947. It wasn't called a collaborating center at the time, but that's what they're called now. Collaborating centers are the means to assisting, coordinating, and making use of the activities and existing institutions around the world so that the WHO doesn't duplicate research efforts or have to create its own research institutions. Collaborating centers support the implementation of WHO's mandated work and develop and strengthen institutional capacity in countries and regions. There are 800 institutions in 80 countries that are designated as collaborating centers, and these include research institutes, parts of universities and academies, and they are designated in particular areas of expertise, ours being mental health. Next, please. So these areas of expertise include nursing, occupational health, communicable disease, nutrition, mental health like ours, chronic disease, and health technology. A little bit more there about the mental health centers. There are 43 centers designated in the realm of mental health and neurosciences, and we are one of 3 of these in the US. The other 2 are Columbia University and Loma Linda University. Next, please. So what does this designation mean? The designation is actually a legal contract to assist the WHO on agreed upon terms of reference, or TOR, that are set forth in our application when we applied for this designation. The work included in the contract is unpaid. However, you can be contracted to do additional paid work that's solicited by the WHO, as we have. The collaborating centers can either report to the WHO regional offices. If we did that, it would be the AMRO office. But ours actually reports to the headquarters in Geneva because our work is considered to be of global significance. So a little bit more about our actual collaborating center. The WHO consortium, or sorry, the UW Consortium for Global Mental Health has collaborated with the WHO since 2019 under the leadership of Pamela Collins, who is now at Johns Hopkins University. We submitted, I think Ian will speak a little bit more about some of that early work that we did. We did some situational analyses for the first countries that were working with the Special Initiative for Mental Health. We submitted an application for designation in 2022 and then received a designation as a collaborating center in August 2023. And it was Pamela Collins' vision to do this as she was the leader of the UW consortium at the time. Our co-directors for our collaborating center are Lydia Schwastiak and Ian Bennett. Next, please. So we are contracted. We applied in our application that we submitted in 2022. We submitted it with 3 terms of reference. And we have 3 terms of reference, and there's a different faculty in charge of each of those. So collaborative care is led by Dr. Lydia Schwastiak. She will present first today. Child and adolescent mental health is led by Larry Wisso, Dr. Larry Wisso, and he will present second. And the Special Initiative for Mental Health is led by Dr. Ian Bennett, and he'll conclude our presentation. So handing it off to Lydia now.
Great, thanks so much, Leah. Thanks for that great background. So yeah, I'm going to present one of the pillars of our collaborating center, which really relates to kind of large scale implementation and scaling of WHO's version of the integrated care model, collaborative care, within physical disease programs with a large focus on work in low and middle income countries. So the next slide, Larry, kind of provides the rationale, not just for this integrated care, collaborative care, but really for what Larry and Ian are going to talk about as well. I think everyone kind of attending this webinar is aware of just how prevalent mental disorders are. There's more than 1 billion of people in the world who live with a mental disorder, and the high costs of disability and morbidity and premature mortality associated with mental disorders. But the focus, the rationale for integrated care really is the treatment gap, which is the proportion of people, the difference between the proportion of people living with a disorder versus those who, compared to those who are receiving treatment. And this has been recognized as a major public health challenge for probably 40 years. But what we see is that the gap is persisting over time, and the gap is not evenly distributed across populations, so that in low and middle income countries in particular, 3 out of 4 people with mental disorders do not receive care. So really kind of the rationale for the work. So one solution for the mental health treatment gap on the next slide that's gained attention really by healthcare systems, policymakers, WHO over the past 10 or 15 years has been specifically the integration of behavioral health services or mental health services into physical disease programs. And, you know, this effort is very intuitive. It increases access to mental health services by literally bringing them to settings where people are receiving medical care. So I think the concept of integrated care is very familiar, you know, to folks in our department, but a lot of the early work was done in primary care, sort of general clinics by lay workers. But this is really sort of a decision to look at places that have really underfunded and undersupported specialty mental health care sectors to really think about physical disease programs, so HIV care and treatment settings or NCD care settings that have chronic disease infrastructure, and that this can be leveraged to provide mental health services. And so, you know, this is infrastructure in terms of staff. A lot of kind of primary care clinics are staffed by lay workers or nurses. In a typical HIV care center or NCD settings, you have physicians, you have workflows, you have tools for tracking processes and outcomes, aggregating and reporting outcomes. So, you know, WHO recognized in the most recent action plan, Mental Health Action Plan in 2019, 5 priority NCDs, and mental disorders are considered a priority NCD. So we're really thinking about how can we, how can we begin to integrate mental health services into physical disease programs. And over the last couple of years, there've actually been specific targets for integration. It's kind of moved from being a recommendation to, like, the Global AIDS Strategy, for example, is really sort of requiring sort of 90% of people living with HIV have access to mental health services. So these are targets for healthcare systems. So I think what we talk about integrated care, it's really important to kind of define what we mean, what kind of models are we talking about, and I think the field has suffered a little bit from lack of consensus definitions. And when you look at systematic reviews, I mean, over decades of work, there's probably been literally hundreds of models that involve even just basic training, access to consultants. But I think, what we want to emphasize today is really thinking about an integrated care model that has dedicated staff delivering psychosocial interventions, that sort of subset of models. So you've got people typically, it's either existing staff being repurposed or adding new staff. And one of the advancements, even within that literature, one of the advancements that has made a real difference in increasing the effectiveness of these models, of integrated care models, is this idea of a stepped care model, a structured approach that's driven by data that matches treatment intensity to complexity. So an example of this, and the figure sort of illustrating this, an example of this is work that we've been doing over the last couple of years in Mozambique in HIV care and treatment settings. The disease prevalence is still pretty high, and so people with a new diagnosis come to clinic to establish care. There's a lot of distress. They'll meet with a peer counselor, and then that works for most people. That relieves distress, and they're doing fine. But if we screen for depression or we notice kind of more persistent symptoms, they can be referred to a social worker for psychological intervention, and that works for most of that group of people, but those who aren't getting better, and so on, sort of up to the point of specialty referral. So, this data-driven approach is seems like a really core part of the effectiveness of integrated care models. So the collaborative care model on the next slide is an example of a stepped care approach. And I think this model is also very familiar. It was developed in our department. Jürgen, the lead developer, and a lot of the research, a lot of the 100 or more clinical trials on this model have come out of colleagues from this department. But what is distinctive about collaborative care, sort of the good news and the bad news, is it's a multi-component model, and it's fairly complex and resource intensive, but it's a team-based approach. It's not just individual staff kind of coordinating. It's really the team is working together as they do in the chronic care model, and there's a dedicated behavioral health care manager. And the approach to the clinic is the clinic is supported through population management. So patients and process and outcomes are tracked in tools like registries, and it is very data driven. So at the individual level, clinicians working one-to-one with patients are providing measurement-based care with patient-reported outcome measures, and treating to target depression response and remission, and then at a clinic level, at a caseload level, there's also kind of aggregating data and kind of thinking about the caseload performance. So when we think about the collaborative care model, again, hundreds of clinical trials across populations, settings, disorders. There's a lot of evidence for effectiveness, but what we've seen is that there's been sort of trouble with kind of translation out into routine care settings, and this has been particularly true in low and middle income countries. So kind of started talking about the mental health treatment gap, that there's sort of limitations, barriers to access to any services. But what's been well defined by our implementation science colleagues is that there's also, when we look at people who do receive care, there's barriers to receiving evidence-based services. It's harder to receive an actual evidence-based intervention. And when we look at settings that have implemented evidence-based interventions, those can drift over time because there's not a lot of fidelity monitoring, a lot of support for clinicians. There's a lot of clinician turnover. So collaborative care has been true for collaborative care as it is for a lot of evidence-based interventions, that it has not, when it's been rolled out, it's been hard to maintain fidelity. And I think the additional implementation gap that I'll point out for collaborative care is that we're talking about people living with HIV and one or more behavioral health disorders. Interventions that address single disorders at a time are not as helpful as really having a team look holistically at someone's, kind of whole picture, everything they're trying to manage. So we looked at this a couple of years ago. Some colleagues, my colleagues who worked on the independent trial, it's the next slide, Larry, which was a multi-site randomized trial that demonstrated the effectiveness of collaborative care to improve depression and diabetes outcomes in patients with poorly controlled diabetes in diabetes clinics in India. We had this clinical trial, and some colleagues who were working in primary care in India on a clinical trial that had an implementation component, and a third group of colleagues who had an implementation trial of collaborative care in rural Nepal hospitals. We kind of looked together at what's going on with implementation, where are the challenges with implementation of the model, and really using the WHO systems framework, really looked at where were of these domains in the framework, where were the main implementation challenges, and really saw that in our studies, at least, major workforce challenges and service delivery challenges, which are, kind of resonated with me in sort of thinking about safety net settings here at home. And so really kind of thinking about how can we address workforce and service delivery challenges. So getting up to speed, the kind of thinking about the WHO work over the last handful of years. In 2018 or so, on the next slide, Larry, the WHO decided that integrated, going all in on integrated care, wanting to scale an integrated care model. There's so much robust evidence for collaborative care. Let's try to develop tools to support the scaling of the collaborative care model. So so a group of us from the AIM Center, Jesse Whitfield, Diane Powers, and I worked for a couple of years with WHO to draft an implementation manual on how, based on the AIM Center, 15 years of experience, how do you kind of begin to roll out? How do you go through the phases of implementation? And this was kind of a long multi-year process. We had a draft, we had multiple expert meetings, a lot of input from people doing this work around the globe. It was really interesting work over a couple of years to finally get a model, a version of the manual that could be field tested. So the goal was to develop a package of implementation materials that countries could use to develop and sustain their own model. So on the next slide kind of shows the vision for field testing. WHO had some funding from NIMH for a 3-year pilot to field test the manual that we developed, and the model had identified and recruited 9 HIV clinics in Ghana and 3 NCD clinics in the Dominican Republic. And we, developed situational analysis, conducted situational analyses, finalized the implementation manual. We developed the training plan, and the evaluation plan. We were really at the point of training the teams and launching the programs. After we were in Geneva last October, we were really planning to train the teams in, early in this spring. And then unfortunately, this was one of the grants that NIH terminated. So the last slide is kind of talking about how we've pivoted, have not given up hope about really being able to produce this very valuable kind of set of implementation materials. So our current activities right now are really initially kind of thinking about other funding. Can we get this field testing done? Can we find other sites? But now we're really sort of also finalizing training materials and developing some companion materials for the implementation manual. So I think the next slide is you, Larry. I'll turn it over to you to shift into our next kind of scope of work.
Well, thanks so much, Lydia. And it's a nice segue in many ways. So I'm going to try to talk just very briefly about some of the child work that we've done and hope to do. Just to make Lydia's point, again, this is some data from the WHO about the median number of annual child outpatient visits comparing low, middle, upper middle, and high income countries. And if you look at the bottom, the high income countries is practically 1,000 annual child mental health outpatient visits per 100,000 people. So 1 per 1,000. And then if you look at the low income, it's 4. And the, in terms of the number of mental health workers per 100,000, it's 5 and 100-fold less in low-income countries. So again, a huge gap both in services and in people power. So there are to approach this, and as Lydia said, the big thing is try to bring the services to where people are. So in child work, as in adult work, trying to integrate mental health services into primary care and specialty care are major efforts. But schools are the other big place where we find children, and so bringing mental health services to schools is important. There's a ton of school mental health work that goes on here at the university in the Smart Center. This is only one tiny little sort of piece of it. And so one of the projects that we have been involved in is the School Mental Health Implementation Network, which was a collaboration with the WHO EMRO, the Eastern Mediterranean Regional Office. And its goal was to try to both trial a school mental health intervention in particular in Pakistan, but also to set up essentially a learning collaborative with individuals from other countries, from Jordan, from Iran, Pakistan, and Egypt, and the UAE ultimately, where those countries could also work on trying to implement school mental health programs. And part of the idea of doing this at this multi-country level was to really emphasize the fact that you really had to approach this, as Lydia was saying, sort of in the much larger context of just how services and government and are organized in any given place. Just a quick picture. This is one part of the team meeting at one of the other WHO collaborating centers at the Institute of Psychiatry in Islamabad. So the main goal of this particular SHINE project was to take a paper mental health, school mental health manual that had been put together at the request of the EMRO office, and to try to figure out how it could best be disseminated. And to make a very long story short, it turned out that if you thought about what the challenges were to trying to disseminate a school mental health intervention within a low-income country, that one of the single biggest things that was found was that actually the teachers themselves were individuals who had to be really catered to in a very particular way. And in particular, because the teachers said, we're already incredibly overwhelmed. We already have enormous limitations on the materials that we have available to us. We have problematic relationships with the families that send kids to us for reasons which may or may not include getting an education. And we're very stressed. So the resulting manual, the online intervention, was meant to be very entertaining, very interactive and online, was supplemented by a sort of ask me any question chat bot that the teachers could use. The approach that was initially in the manual, which involved interventions for particular conditions, was scrapped in favor of a transdiagnostic, problem-oriented approach that avoided labeling kids with any particular problem. And the intervention included in materials for the teachers to think about how they could manage their own stress as they were trying to just cope with the challenges in the classroom. And these materials are available online, various versions of them. The link on the left is a training that is all in Urdu. That was set up for the trial that was going to happen in Pakistan. I'll get to that in a second. The material, the link on the right, is on the EMRO website. It's available in Arabic and English, and anyone can take these courses just by clicking on them. So This particular trial was interrupted by another natural disaster, which was the COVID epidemic, which made it impossible. The schools in Pakistan shut down, and we were not able to carry out the trial. But it's now getting back up again. Although, again, this is another NIH grant that is precarious. We haven't heard a final acts on it yet. Usman Hamdani is the PI in Pakistan, and Shannon Dorsey and I are co-investigators here at UW. But it's going to look at a stepped intervention that will involve this teacher training, but then seeing whether we can add on a guided self-help CBT for adolescents who receive it, and trying to understand what combination of a essentially universal teacher training versus individual intervention for adolescents would be the best to address problems of low mood. Another project that we got involved with was with the UN Refugee Works Administration, which, as you probably know, is the organization that supports Gaza. And so this was all work that it was based before October 2023. But the UNRWA schools had decided that they, in response to the last really big wave of war there in May of 2021, that they wanted to test the feasibility of screening children who were entering the elementary school level to see if they could identify kids who had been had traumatic, stress and related disorders, and offer them help in the school setting. And as an initial hypothesis in doing this work was that there would be sort of greater impact on kids who schools were closer to, sites of damage. So the map here, the blue sites are the blue dots are the UNRWA schools. The red dots are where there was damage. The UN also, does wonderful surveillance of these sorts of things. So we're able to geomap where the damage was, overlap that with the map of the schools, and say, well, kids who are attending these schools where there was more damage would sort of have more impact. It turned out actually that was not the case, that the sort of subjective feelings of fear were more impactful than the proximity to where there was actually damage. And as one would expect, that lower income families were less able to shelter their kids from the impact of the war. But this is another, piece of work that was interrupted, but hopefully will take up again at some point. The work that we've been talking with WHO now most recently about has been in the area of schools and the overlap of mental health and developmental disabilities. We know that globally, kids with disabilities are very often excluded from mainstream education. That's often the case here, but it's especially the case in many other parts of the world. And that, teacher training and schools are designed to serve kids with a relatively narrow range of so-called normal abilities. But this is particularly worse in places where there are really big cultural and language background differences, plus the interaction with poverty. So kids come to school with a very different background, and rather than being labeled as not ready, they're labeled as disabled. So WHO has been developing guidance for school leaders, helping them try to understand sort of what the goals of education are at a very high level. Is it to actually maximize individual capacity versus develop a workforce? To what extent should teachers be able to adapt to a range of learning styles? Should we be focusing on social skills, because we know that improves academics, but that's not an orientation classically in many countries. And also, how do we generalize the idea that inclusive classrooms are actually a good thing as opposed to a bad thing, that they improve outcomes for kids across differing abilities. So this is really the next frontier. And interestingly enough, it's the next frontier for us as well. And I just want to mention before I finish that there's one other project that Sarah Walker, one of our faculty colleagues here, led. This was a direct collaboration with Chiara Servilli, who's one of the child mental health people at WHO, was a review paper on the scale up of child mental health services globally, and different ways that that scale up is happening. And this paper has been really useful to us, and Sarah and Noah and Sally, all folks here were the real major contributors to this. So I think I get to hand it over to Ian.
Thanks, Larry and Lydia and Leah. You guys really set me up well for the last little part of our presentation, which is the third TOR, which is our contracted responsibility to address these different topics. This one is focused on the WHO Special Initiative for Mental Health, or SIMH. This is, next slide, a global effort which was started now more than a decade ago, and we, under the support and guidance of Pamela Collins, our beloved and greatly missed fearless leader, who Jürgen and the Department of Global Health brought together, through their search to bring. And I'll just put a plug in. That really, her impact continues, and it would be really awesome to be able to find someone and have a role like that from our leadership globally to reinvigorate the work that is now, I'd say, like, there's a lot of not coasting, but we've really benefited and are making a lot of progress because of the tracks that Pamela's laid down. So anyway, the idea is to expand access to quality mental health for 100 million more people in 12 priority countries by 2023. We're beyond that now, of course. We started in particular involvement working with, as a contracted deliverables, a contractor for deliverables around landscaping or situational description of what's happening in the initial 9 countries. There were 7 originally, and then 2 were added, and they're listed here. We'll go on to the next slide. The first thing we did was this environmental scan, which Pamela Collins really led. She coordinated us getting that contract and led a very rapid effort that was truly phenomenal, that we got as much done as we did. I was in charge of the Philippines, which I have a personal connection with. I was born and had my childhood in the Philippines. But also, I'll bring up that we have a real interest, or we did at that time, and hope will continue, to have more of a footprint in Asia and the Pacific Islands, which, because we share the Pacific Ocean with that region, and we have not historically had much connection there. That was a major goal of my work with the center. We were able to generate reports, brief reports, which are available on the website at the WHO, and have been useful, I think, in helping launch the SIMH work. Next slide. We also received a contract. I was the PI for a contract specifically with the Philippines, and this was building on relationships developed during our work in the Philippines on the environmental scan, to help with dissemination of work that had been aligned with the Special Initiative in Mental Health. There were national efforts, including a national legislation which required rolling out mental health care to the public, which was very much aligned with SIMH. The problem that they were finding, though, the WHO office in the Philippines, was that they were having trouble getting the uptake in the 7 provinces, which were part of the SIMH effort. And they felt that our partners there in the Department of Health felt that a key missing piece was the support of the provincial leaders, so the governors of the 7 provinces. And so it was really interesting. I worked with ITEC, and at that time Pamela was the director of ITEC. And we used their expertise in developing curriculum to create a unique curriculum, longitudinal 6-month curriculum for governors, to help them understand something more about mental health in general, the problems, and what the opportunities were and responsibilities given the national legislation to address this issue. It was super interesting. We did that in over about a 6-month period, creating that curriculum, and then handed it over to the Department of Health in the Philippines. Next slide. So here's a little bit more information about that. So, the focus issues which we identified related through a user-centered design approach, a human-centered design approach, related to governance and leadership in mental health. So we needed a curriculum that was appropriate to the governor, which was an interesting perspective, and also translating that national mental health law into local policies and budgets. What are the multi-sectoral coordination issues? What's the business model? Why does it matter for the business and economic development of the region, of the province, to be working on this mental health stuff, so that the governor would be interested and also be able to bring in the resources that they had control of. Next slide. The last project that we were funded to do, these 3 projects were all funded efforts. We are just in the middle of now, and again, I'm the PI of this, and it's the end-line evaluation of the SIMH efforts in the Philippines. And what we were contracted to do was to first create a plan for that evaluation, using a mixed methods approach, both quantitative and qualitative. We completed that in December, and part of our goal was to identify a local contractor that could do the data collection, the new data collection beyond what we did, which was desk reviews. And I really want to call out Yue Wang, who is a PhD candidate student in our global health, mental health program, global health program, and is working with worked with us during her PhD work. Yue is listed as a part of this presentation, but asked me to present. So I just wanted to call her out. And Keshet is been working with her quite a bit. I don't know if you guys know Keshet in global mental health, but she's wonderful. And I've been working with them on making sure that Yue is we're able to take advantage of her skills during her PhD time and afterwards, I hope. But anyway, so we are now supporting the in-country contractor that's doing the work to collect this data, and that should be wrapped up by December, and we'll be able to turn that into a report, which we are also being asked by the WHO to really create a model for these end-line evaluations, which we hope will translate into supporting all of the other countries involved with the first round of SIMH to help them with their evaluations as well, which would really keep us connected with the WHO on all of this work. Next slide. The last thing I wanted to bring up was just to call out again the wonderful work of Yue Wang. We, over the last couple of years, because of our collaborating center status and the responsibility that we have to provide resources without charge to the WHO. That's one of the things that we are signed up for. Is to help them with analyses of a related project, the WHO's SIMH Sentinel Data project. And so UA and I, and it's, I'm helping, but UA is doing the hard work of the analyses, and we're working with the WHO folks on this. Next slide. So Sentinel Data, the idea is to establish a standardized monitoring to assess progress of the SIMH, across the country, across the world. The core elements include Sentinel indicators, country implementation, outcomes, and comparative learnings. The focus countries for this Sentinel data analysis are Ghana, Argentina, Paraguay, and Bangladesh, all of which were part of that in the first round of the SIMH efforts. The goal is to have reliable country-level mental health data for policy and planning, evidence-based for scaling integration to primary care, and lessons for other SIMH countries and beyond. Next slide. So these are some of the many, many dozens of analyses that UA has done, and we are working back and forth with leadership at the WHO around this work. So these 4 initial countries using data transferred, de-identified data transferred to us from the WHO. Just some interesting diagnoses differences across the different countries. And one of the things that's immediately obvious is that these are really different, right? And one of the things that it's important to know is that each of these countries has very different sites in which they're collecting this data. So it's not really fair to compare, the countries and what the diagnoses are there. Because, for example, Ghana, which it has a majority psychosis diagnosis, that's being collected in a specialty mental health hospital, as compared to the other countries, which are much more ambulatory and primary care. Anyway, just a little bit of a snippet of that. And our next slide. So here are treatment coverage outcomes related to, whether or not they got any of the patients that were included got any of these outcomes, and whether they received more than one kind of treatment. You can say in this case, they're much more similar than they were in the diagnosis domains, which is interesting and provides an insight into the health services components of this work. Next slide. And here looking at initial data on treatment effects, and we're looking at the HODAS 2.0 average score. So a lower score is better as you go across. I'm not super familiar with this measure, so others might need to help me with this if there are questions on it. But we are looking at, is there evidence, and this is more about setting up an infrastructure for this, for benefits of these treatments. And you can see that for 3 of the 4 countries, there are benefits. We didn't do any specific significance evaluation so far on this, but more descriptive, except for Argentina. And again, we need to think about, what are the actual diagnoses that we're talking about as well. Okay, next slide. I think that's it. We still have 10 minutes. Woo!
We do. We have time for questions. So first, thanks to all of you for being here today. Really appreciate it. So yeah, folks at home, we don't have any questions submitted yet. So go ahead if you have anything, type them into that Q&A feature, and we'll get those questions answered for you. I guess in the meantime, while we wait for people to type their questions in, since we basically have a panel here, do you have any questions for each other while we wait?
Well, I do actually. I'm sorry for jumping in right away, just to get things going. I do want to, I think that we're in an interesting moment with Global Mental Health Center, and, for the center that we had that was really had resources and a lot of movement. has dissipated somewhat because of not having the leadership that we had before. So I guess I would ask, Larry and Lydia, and maybe Jurgen as well, what your thoughts are about, what I alluded to, like what I think is really a critical need to bring in or to identify someone at UW already who can have that kind of role that Dr. Collins had previously. So just thoughts and discussion.
And before the rest of you answer, I'll just let you know that Jurgen had to jump off to go do an interview, so he's not ignoring the question. That's why he's not here right now.
We're waiting for Jurgen to respond. Yeah,
Yeah,
it's going to
he's
be
not
hard.
going to.
It's
Well,
impossible. There's
we
there's
should
no
have,
replacing Pamela, Ian. So I think,
yeah.
but I think it is. Where I thought you were going with this was just the challenge of doing global work right now, and I think there are
Yeah.
a lot of people who, we have a lot of colleagues who have global grants, and just really understanding how how we need to pivot and how we need to continue to collaborate, not just with WHO, but with our international colleagues and potentially explore funding sources. And so it's a different game. And I think it's different for certainly trainees, fellows, PhD students who are coming up. So I hope the Collaborating Center can be sort of a place where people can come and sort of think through ideas. But yeah, it's
Well, and I think also the collaborating center model, as Leah pointed out at the beginning, was really based on the idea, I think, that a lot of these institutions, these well-endowed institutions in high-income countries, would be able to essentially make in-kind contributions to doing this work. And I think that many of us who've done work with either the regional, organizations that make up WHO or WHO itself, have over the years generally found ways to do it essentially for free, or to fold it into other projects. And that's challenging as our own domestic resources are drying up, and we also face an uphill thing, as we have at various times in the past, being from the United States, where we this is not the first time, at least in the course of my longish career, that being from the US was not always the easiest thing to be in other countries.
well, we actually have two questions in the Q&A, and the anonymous attendee is sort of was asked what I was just about to say about refunding. How have global mental health strategies been applied domestically? And I think that's exactly, certainly I personally have been thinking about, what is that translation between work in low and middle income countries and what we do in low resource safety net settings here, low barrier settings here. So I think that is definitely, was already an idea that had a lot of traction and enthusiasm, and is just going to be even more important as our low resource settings become even more under-resourced. We have a question about data collection too. So I don't know if Larry and Ian, you can see the two questions. You might want to weigh in, or Leah.
Sorry for all the screen switching. I was getting to that. I just want to say that.
I'll go ahead and read it out loud, because they can't see it at home.
Okay,
So
good, okay.
for the folks listening, the question is, does your data collection include centenarians
Oh, and super centenarians.
and super centenarians? Yeah.
They're not excluded. That certainly that category probably currently is not noticeable because it's collapsed into the higher age group. So, but it's a great question. I'll bring it back to the SIMH folks to make sure that they're paying attention to those super livers. I think I see there's a question in our chat too. So yes, so a couple of things. I was the PI of a grant that was connected to Dr. Veith's work in Vietnam, and that was not directly part of the center, but was happening at the same time that went while we were still had a kind of relatively well-resourced center separate from this, on global mental health. And there's certainly, please send me an email and I'll get you connected. We have lots of, it was really amazing how many folks of Vietnamese heritage got involved, tracked me down, and made sure that they were involved with that project. It's really cool to, and it was very fun to have people who are based in the U.S. but of Vietnamese descent involved with that work.
Sarah has a great question in the Q&A about, are there key lessons learned from global integrated care work that you'd bring back and spread here at a local and national level that we aren't thinking about right now? I'll let Lydia start on that while I think about it.
Yeah, well, I think, thanks, Larry. Yeah, Sarah, I mean, Sarah's, the work that we're doing around sort of large scaling at a large level is, a lot of people from the AIM Center have been involved with, and Sarah's obviously been very thoughtful about it, kind of domestically, large scale implementations in the US. Yeah, I don't know. Maybe the important thinking about like what are the bullet points that you would kind of distill, like the importance of tailoring, really thinking about kind of the phases of implementation and how are individual sites, even countries thinking about the determinants, the barriers and facilitators in their own context, and really thinking about like, kind of work with the ministries. And so in some ways, frankly, I have found the work in other countries to be a lot easier. There's not like restrictions around scope of practice and licensure, and it's been relatively more kind of flexible to do task sharing, but probably like the main implementation lessons relate to, kind of a really thoughtful, systematic approach kind of throughout the phases of implementation. But yeah, a lot like really great questions, Sarah, and I think there's a lot more to say about it. I don't know, Larry, what do you?
Yeah.
I feel
Well,
like
yeah.
I was
Go
gonna say,
ahead, Larry.
yeah, I was gonna say really quickly, is that I feel like the one big lesson that I've learned and that we're trying to now, I think, do in Okanagan County and Whatcom County is to really focus a lot on how to build a self-sustaining network of people in a community, how to knit agencies together so that they support each other in doing the integrated care work rather than having the primary care practice or that site be sort of independent and needing outside help, whether that's for training or whether that's for ongoing staff development or other kind of win-win things that they can do to keep each other going, especially after we leave.
Yeah, I mean, I think that the first thing I would say is that it's exactly the same in most ways in every setting I've ever been in, whether it's out in Vietnam, whether it's in King County, whether it's across the state, whether it's down in California. Most of the dynamics are really, really similar. And the issues then are more about resources and how you harness the resources that you have there. So, totally complementing what Lydia and Larry, you guys are saying. That there's in addition, and there's so many things. Everything that I've learned in Vietnam, I have applied in, LA, where working there. These relationships at the clinic level, the way that people are interacting, getting them the idea of this team approach as compared to just like our standard, more urgent care model of primary care, and moving forward in population-based services. These are all exactly the same thing that we need to move forward in the global south as we do in high income countries. And I would go back to Pamela's, really important point to me, an epiphany to me, that global health doesn't just mean the global south, it means everybody, right? I just have never found something that I learned in one setting that wasn't applicable in every setting.
Yeah, no, that's a great point. And I think the other comment I would make is just the importance of working with partners and really, valuing expertise. And one of the really humbling lessons I've learned kind of with work in King County is just things like the outcomes have to matter to people, like really thinking about your model and engaging the people who are going to be delivering the services and who are going to be receiving the services, and just how important it is for those partnerships. So thanks for the great questions. Those are really
Yeah.
wonderful questions.
Yeah, and I think with that, it brings us to the top of the hour here. So we'll go ahead and wrap up. But I want to thank all of you for being here. It's actually really fun when we get to end it with a conversation like this, having a group online. So I think it's a good start to our new academic year of Grand Rounds. So thank you again, everyone online. Thanks for watching, and have a good weekend. We'll see you next week.